So in today's chapter, we will be discussing about ICU, labor ward and ICU. Those who have the textbook, please mention the page number in the chat box. So first we will check the labor and delivery room infrastructure. Only one table is given for this. So if you have a labor room or a delivery room in your hospital or in your healthcare setup, you can convert this table into a checklist form just to see that all the areas, all the equipments and physical structures required for a good functioning, well functioning labor room, is it present in your hospital or not? Okay. So the first thing, having a clock, okay, having a hand washing area which has a good clean water supply, soap, okay, nail brushes are not used anymore, okay, clean towels, delivery bed, okay, if these things are available or not, okay, a stethoscope, thermometer, fetal stethoscope, baby scale, blood pressure machine, okay, um, ampu bag. If these things are available or not, just check. You can make a checklist out of this. Sterilizer, desktop sterilizer for forceps, curtains for privacy, clean surface for other delivery positions apart from lithotomy. Okay. Work surface area where a newborn can be resuscitated by a pediatrician, which is near delivery beds. Biomedical waste container collection area. Okay. Clean linens, bowls with plastic bag uh, for placenta collection. Okay. A radiant warmer for newborn baby. Mucus extractor, suction tube, good spotlights. Okay. For when you're doing episiotomy and all, good spotlights are required. Room thermometer to control the temperature of the room. Delivery instruments, the entire delivery kit. Okay. Sterile scissors, needle holder, artery forceps, clamp forceps, dissecting forceps, sponge forceps, vaginal speculum, other clean supplies, gloves, apron, catheters of different sizes, syringes, needles, IV tubes, suture materials, okay, for episiotomy repair and all, antiseptic solutions, spirit, swabs, sterile swabs, okay. These things should be available in any labor or delivery room, okay. Clean plastic sanitary pads for mothers to use after labor, clean towels, okay, for wrapping the baby, cord ties, blanket for the baby feeding cup if the baby cannot suck on the mother's nipples, baby feeding cup, palada feeding is given, bed nets, partograph for record, okay, a partograph, every labor will have a partograph, labor record, labor and discharge registers. Coming to ICU. So recommendations, initial planning, there should be a team setup, okay, before the ICU is developed, and initial planning is done of how many beds are required in the ICU and all, okay. Decision about the ICU level, there are 3 levels of ICU, we will discuss that later. So making the decision is also done before the ICU is developed. Central nursing station, where will you place your nursing station in the hospital? Which area will you place the nursing station. Okay, that's a very key infrastructure in the ICU. Nursing station is the spine of the ICU. Okay, so the placement of the nursing station is very crucial. It should be usually equidistant from all the beds. Equipments that will decide the level of ICU. Okay, all the levels of ICU will not have the same type of equipments. Okay, how well equipped your ICU is, it is determined by the level of the ICU. Okay, all ICUs will not have ventilators, so for 24 hours, 24/7 utilization. Okay, support system recommendations. uh, Physiotherapy, other technicians, biomedical technicians, laboratory technicians, radiography technicians, who all will be the support system for the ICU. How and when all they will be available? Will they work on rotational duty basis, or will they be available 24/7 round the clock? Okay, those decisions has to be made. Environmental planning. Where will the ICU be located? How far or how near other departments will be to the ICU, how to reach the ICU, the area of the ICU, okay, how close it is to the public, how far it is to the general public. Okay, these decisions have to be made. Human resource development, that is the HR team for the ICU. Usually the technicians, doctors, intensivists, nurses, okay, they all are the major human resources for the ICU. Research, data collection, documentation, and record keeping. Here, based on research, what research you have to do based on your population's requirement. Okay, where identify the gaps of existing healthcare services with regards to the ICU in your hospital, around the hospital. Okay, where you are lacking, that has to be found out. That area has to be found out. You have to research about it, collect data, document it. Okay, and based on that, decision making will be done. So ICU team, it consists of intensivists. Intensivists are doctors who are specialized in intensive care units. They are called intensivist. Administrator of the ICU. Okay, they will take care of the number of admission and discharges in the ICU, to control the traffic in the ICU. Finance officer, they will take care of the pricing, bed structures, etc. Architects and engineers, in the initial phase, they are required. Later on, their work will be given to biomedical engineers, maintenance engineers, okay, nurses, and other relevant members. These are the core ICU team while the development of the ICU is going on. Coming to the levels of ICU, there are three different levels: level 1, level 2, and level 3. Level 1, it's small district hospital or a small private hospital or even nursing homes. They will not have more than 8 beds. Level 1 ICU will not have more than 8 beds. Resuscitation is done. Short-term cardio respiratory support is given. Defibrillators are given. Okay. ABG airway breath analysis is done. Okay, sorry, arterial blood gas analysis is done. Ventilation for 24 hours to 48 hours only. Level 1 ICU can afford. After that, you have to, if the patient requires to be on ventilation, they have to be moved to other healthcare facilities. Non-invasive monitoring is done. Invasive techniques of monitoring is not used in level 1 ICU. Safe transport arrangements are done. Staffs should do short training courses from outside. Okay, usually they will not provide training facility here in level 1. Short training courses staff should do from some outside academies. In charge is a trained doctor in this ICU. Blood bank support would be there from an outside blood bank, okay, not an in-house. Basic clinical laboratory will be there. Only basic clinical tests can be done, basic laboratory test can be done. Critical care medicine book will be available. In level 2 hospital, these are larger general hospitals as compared to level 1. At least 6 to 12 beds of ICU is available here. Director or the in charge of the ICU is a intensivist. In level 1, it was just a doctor who is in charge. Here it would be a qualified intensivist. Multi-life support system is available. Multi-system failures, multi-organ failure cases can be treated here. Invasive as well as non-invasive methods of monitoring is used. Ventilation is given for more than 2 days, okay, as long as the patient requires. Long-term ventilation availability is also available. PC pacing, ABG analysis is done, electrolytes testing is done, okay. Other routine diagnostic support is also given. Microbiological lab reports are also mentioned here. Nurses and trained doctors in critical care. They should be trained in critical care, the nurses who are posted here. CT and MRI is available in the hospital. Research development department may not be available, not compulsory. Cardiology department should be available in the hospital. There should be a HDU facility. It's desirable, not compulsory. HDU is high dependency unit. Blood bank, either own or outsourced. In level 3 ICUs, tertiary, all the ICUs that you see in tertiary care hospitals automatically are level 3 ICUs. Bed strength is around 10 to 16 with one or multiple ICUs. Here as well, invasive and non-invasive monitoring both is done. Long-term care can be given. Intra and inter-hospital facilities. Multi-system care, that is multi-organ failure patients are treated here. Fellowship courses are conducted in the hospital itself. Their own staff can apply for these courses, study these courses. Bedside X-ray, ultrasonography machine, bronchoscopy, dialysis is also provided. They should have their own CT and MRI, the hospital. They should have their own blood bank support. 1:1 is the nurse-patient ratio in level 3 hospitals. Otherwise, the care will not be adequate enough for the patients. National and international research provisions are available here. Research department is a requirement here in level 3. Minimum 100 square feet patient area for each patient should be provided. Ethical committee assistance will be there. Wherever research is done, wherever a research department is there, ethical committee assistance will also be there. Human resources, HR requirement for ICU. Team leader, person who spends more than 50% of their time in ICU. Resident doctors, postgraduates, minimum 1:5, at least one resident doctors for 5 patients. Nursing staff, 1:1. for all ventilated patients. For patients who are not on ventilator, 1:2 or 1:3 at night. 1:2 at daytime, 1:3 at night time. Okay. So patients who are not on ventilator, one nurse can take care of two patients. At night, one nurse can take care of three patients. Respiratory therapist should be available, physiotherapist, IT personnel, biomedical engineers, nutritionists, housekeeping staffs. So 1 to 4 ICU beds per 100 hospital beds. If you have 100 bed in your hospital, at least 4 ICU bed you should have. 1 to 4 ICU beds you should have. Okay, if you have 200 beds in your hospital, at least 8 ICU beds you should have. Okay. Again, based on the population of the country, European countries don't require this high number. In India, if you are a 200-bedded hospital, you will require 8 ICU beds at least. If you are in a European nation, if you have a 200-bedded hospital, even if you have 3 or 4 ICU beds, that is enough. Okay, so it is based on the country's population as well. More than 6 ICU beds are not cost effective. It will not be profitable. Okay. More than 24 ICU beds are difficult to manage. A good quality care will not be given to ICUs in the patients who are in ICU if you have more than 24 ICU beds. Efficiency is compromised post 12 beds in the ICU. As soon as you have more than 12 beds in the ICU, your staff's efficiency to provide good care, it reduces. So the ideal range is 8 to 12 beds. That is the ideal range. It will make profit for your hospital, plus it will be a good service that you give to your patients. Okay, this is about the ICU beds. So the ICU bed designing space, 125 to 150 square feet per patient area. If it is a tertiary level hospital, if you have more than 20 ICU beds, at least 100 square feet per patient per bed has to be provided. 100 to 150 extra space to accommodate nursing station, storage, movement area, okay, equipment area, doctors. It should not be, these areas should not be congested, okay. 10% rooms are designated isolation room with 20% extra space than other rooms. So if you have 10 ICU beds in your hospital, at least one isolation bed should be available. So 10% of your total ICU bed should be a isolation room or an isolation bed. Partition between the patients should be there, which should be either fixed or removable to give privacy. Pendant versus head end panel. Height of the monitoring system. You can see here, this is the pendant kind of a situation. Pendant monitoring system, which is hanging from the ceiling, and whatever monitoring system you use, it should be above your eye level, but at a comfortable height. It should not be too high that when the doctors and nurses are trying to monitor the patient, they get their neck pain because the monitoring system is too high. It should not be that high. It should be just above the eye level. Keep the beds at least 2 feet away from the head wall. Space that should be there between the patient's bed and the head wall. Provision of respiratory system, rapid respiratory therapy. Isolation rooms, 1 or 2 isolation rooms should be there, which should be used only for isolation cases, not for any other case. This is a head end panel, very commonly seen in Indian ICUs. The earlier one was a pendant kind of a monitoring system. This is a head end panel wherein at the head end of the bed, all the monitors will be attached. Recommendations, central nursing station. This is the nerve center of the ICU. Monitors and patients must be observable directly through the central monitoring system. That is, when you stand in the nursing station, each and every patient's monitor should be visible to you. Okay, whichever bed has patients, they will have that monitors. It should be visible from the central nursing station. Serves 6 to 12 beds. It should be arranged in an L or U shape. If you have more than 12 beds, you will have more central nursing station. Okay. So based on the number of beds, you will have the number of central nursing station as well. So basically, one central nursing station should take care of at least 6 to 12 beds. HVAC system, fully air conditioned rooms will have the HVAC system, heating, ventilation, and air conditioning. That is the full form of HVAC. Here, tilt and turn windows should be used. Okay, when the HVAC system is not in use, at least you can open the windows. Safe air quality is mentioned here. Clean to dirty areas, the air flow. Okay, in the HVAC system, the air flow is from clean area to dirty area. Okay, that is from the patient area to the dirty area, where dirty areas are considered as the toilet areas, washroom areas, linen collection areas. Minimum 6 air changes per room per hour is maintained. That digitally you can maintain that. Okay, in one air changes means in 1 hour, 1 hour, at least 6 times the entire air in the room should be changed. Okay, and 2 air changes are composed of outside air. Clean air will come from the HVAC system, but 2 air changes should be composed of the outside air so that there is an equilibrium. Okay. Dirty utility, sluice area, that is where the cleaning, linen connection and everything is done. Laboratory area, laboratory, all these things will require 5 air changes per area. These are dirty areas. Okay. Air should be filtered to 99% efficiency down to 5 microns, so that even smallest of virus is also not getting inside the air. It should be a no smoking zone. Heating is given only to comfort the patient, otherwise the temperature should be between 16 to 25 degrees Celsius. And some patients who are going through pyrexia and all, and for them heating is given just to comfort that specific patients. Power backup should be available, generator should be available. So this is the basics of an HVAC system. This is a ventilated room. You can see the blue arrows are the clean air. The red arrows are the unclean air, dirty air. Okay. So unclean air from the ventilated room will be pushed out. It will go into the filter. Okay. And you can see outside air is also coming here because 2 air changes should be composed of the outside air. Okay. So the unclean air along with the outside air, they will undergo filter. Okay. And the filter will cool down the air and it will come back to the room. Okay. You have a chiller and a boiler as well to control the temperature. Negative pressure isolation rooms, organisms that spread by airborne or droplet nuclei, which are less than 5 micron in diameter, they will not be filtered out properly with HVAC. Okay, HEPA filters may be required. So in that situation, negative pressure rooms are used. Here windows don't open. Okay, the exhaust is greater than air supply, which means pushing out the air, okay, is more than the supply of air. You don't have to worry about supplying air. To maintain the equilibrium, air will get in the room. But once the air is in, it gets infected because the patient here is infectious. So now you have to push out the infectious air out of the room. So exhaust system is greater than the supply of air. Pressure differential of 2.5 PA is created in this room. Clean to dirty is the airflow. The air entering is clean, but it gets dirty inside the room, so it has to be pushed out. Air from the room is preferably exhausted outside. Okay, and if the air is going outside, if it is coming back, it will be recirculated only through HEPA filter. If the air is going out and if it is going to come back inside, it has to go through HEPA filter. So this is the negative pressure room. Airflow is passive. You don't worry about it much. Naturally, the airflow will happen. It will enter the room. It will get dirty here because infectious patients are kept here. And you have to push out this air. Air is forced out. You can see the arrows, the size difference of the arrow, the green and red one, the size difference. So you have to focus more on the pushing out of this air. Then positive pressure isolation room protects patients who are at higher risk of infection. Room should have greater supply than exhaust air. Okay, you have to take care of the air that is entering in, not the air that is being pushed out. Pressure difference again 2.5 to 8 pressure PA is the difference here. HEPA filter is required. Without HEPA filter, you cannot make a positive pressure room. So in positive pressure room, air is forced in. So the focus here is the air that gets in. It has to be clean, pure. Okay. A patient without any infection is kept here. You are protecting the patient from any form of infection. Okay. And the air that leaves this room, you don't have to worry about it much. The airflow is passive. Okay. Lighting in the room, natural light is preferred as much as possible. Natural sunlight is preferred in ICUs, and synthetic artificial daylight can be used during night so that the night workers will think it is kind of daylight. High illumination and spot lighting. It's not sports, it's spot, S-P-O-T. It's a spelling mistake here. High illumination and spot lighting is used for specific procedures. And lights, if it is descending from the ceiling, extending from the wall, or carried into the room. For procedures, if you are using some specific spotlight, this has to be used. Either it should come through the ceiling, descend from the ceiling, come out of a wall, or the portable ones, portable spotlight, which you can carry into the room. Shadow-free spotlighting is used, which has 150-foot candles strength. For general procedures, if you're doing general procedures in the ICU, it should be bright enough for the people who are doing the procedure so that there is no eye strain. Okay. Enough light should be there for general procedures so that nurses and doctors don't have to strain their eyes. Okay. Overhead lighting should be at least 20-foot candles at night. Fluorescent lights, that is the tube light, and coated phosphorus lamp, that is tube light, okay, is used for assessment of skin and all. Noise control in ICU, noise level should be under 45 A-weighted decibels in daytime, 40 A-weighted decibels in the evening, and at night it should be extremely silent, 20 A-weighted decibels. Okay, so that should be the noise level. Noise level monitors are available, which will blink. Noise level monitors will blink when the noise level exceeds all these limitations. Okay, so immediately actions can be taken to reduce the noise in the ICU. Next, coming to the high dependency unit, HDU, patient care and level is intermittent between ICU and the floors. Okay, when the patient is to be discharged from the ICU, you put the patient in HDU because the patient can come out of the ICU, but he or she is not ready for the general ward yet. So it is always located near the ICU. HDU is located near the ICU. Staff competency is also similar to ICU. Okay, if it is ventilated patients, 1:1. Non-ventilated patients, daytime 1:2, nighttime 1:3. So same staff competency is used. Unit size 50% of the main ICU. If you have 10 ICU beds in your hospital, you should have at least 5 HDU in the hospital. Okay. Nurse patient, doctor patient ratios can be a bit relaxed because the patients here are not as critical as the ICU patients. They are out of their critical phase. Okay. And in some cases, there is no way of saving the life of the patient. So those patients can also be moved to high dependency unit if they are not put on any ventilators. Okay. It can be used as a palliative care unit as well. So which kind of patients can you put in HDU? Patients who have recovered from any critical sicknesses, patients who are less sick, like single organ failure, patients who require strong observation but not treatment. Okay. So these patients you can put in HDU. So that's about today's topic. If you have any queries, please mention in the chat